Welcome to Healthy Frontiers. My name is Dr. Bizzoni. I'm a chiropractor, and this show is dedicated to the education of our viewers. The guest for tonight is Dr. Jonathan Berliner, an orthopedic surgeon and joint replacement specialist at ONS. His topic is going to be total hip replacement. And let me just talk about the doc a little bit. Nearly 500,000 hip replacements surgeries were performed in the United States last year, and it's not just the elderly and infirm who are going for it. These days, baby boomers who have been active all their lives and want to stay that way are having it done much earlier, in their 50s and 60s. Joint replacement surgeon Dr. Berliner from ONS is here to explain why this surgery is becoming more popular among younger people, and he's going to tell us about a new muscle-sparing hip replacement procedure called anterior hip replacement, which is believed to be quicker and easier to recover from and greatly reduces the pain and risk of complications. Dr. Berliner is with ONS, orthopedic and neurosurgery specialist. He's a fellowship-trained hip and knee replacement specialist whose expertise includes anterior hip replacement, minimally invasive total and partial knee replacement, and complex revision hip and knee replacement. He is a recipient of the John Charney Award, a national award presented annually by the Hip Society for Best Innovative Clinical Research related to hip replacement. He's also volunteered as medical services abroad in Haiti and Nicaragua, among other places. I'd like to welcome Dr. Berliner to the
Thank
show.
you for having me. It's very nice to be here.
Great to have you, Doc. So let's start off right away with the first question. Okay?
Sure.
And I'd like to ask you, let's tell us about the different types of hip pain, and how does one know if they have pain from arthritis or is it from their hip? Go ahead.
Sure. So hip pain is a very common problem within the community. When a patient comes in complaining of hip pain, there can be multiple types of hip pain. So the easiest way I think to classify them is into three different areas. There's posterior hip pain or pain in the buttock. There's pain over the lateral aspect of the hip or on the side of the hip. Okay. And there's pain over the front of the hip or in the anterior hip region. So when we start thinking about pain in the back or in the buttock region, typically that's related to the spine. Patients often have degenerative changes in both the spine and the hip. Those can certainly happen concurrently. Right. And so that's why it's important when a patient comes in to see me in clinic, we do a full history. We ask all the important questions, such as how long they've been having pain, where the pain is, any exacerbating or alleviating factors. We look at the imaging to determine, whether the x-rays show degenerative changes in the back or the hip. And so we formulate a diagnosis based on all these different data points.
Yes.
For patients who have pain posteriorly or in the back, oftentimes the degenerative changes in the spine can result in nerve impingement, right. And that can result in pain over the back of the hip, that can radiate down the leg, right. That can involve the thigh and even go all the way down to the foot. Yeah. Patients who come in with pain over the side of the hip or the lateral aspect of the hip, that's often due to other reasons. That can include bursitis, which is present over the side of the hip. There can be tendinitis. There's a large group of muscles over the buttock and the side of the hip called the gluteal muscles. You can get tendinitis in those muscles. And oftentimes that's treated a lot differently than actual pain inside the hip joint itself. Yes. Pain over the front of the hip or in the groin is classically pain coming from inside the hip joint. And this can certainly be arthritis. It can also be muscular in nature. There are large tendons that travel over the front of the hip. Right. Patients who have pain coming from inside the hip classically present with pain in the groin or over the front of the hip. That pain is exacerbated with squatting or rotating the hip or other activities. So that's why it's important when patients come into the office to really do a thorough history, exam, figure out exactly where their pain's coming from, as well as look at their x-rays and their imaging to determine exactly what the cause of their pain is.
Right, because I'm sure as you see, a lot of patients will walk in your office and say, "Doc, I have a bad hip."
Yeah, exactly.
Take it from there.
Yeah, they can grab any portion of the body, anywhere from the back all the way to the front of the hip. Right. So it's important to distinguish exactly where that pain's coming from.
Okay, so Doc, how does arthritis develop in the hip joint?
Sure. So firstly, it's important to clarify that arthritis is kind of a broad term. There are many, many types of arthritis. Arthritis really classifies pain in a joint or a pathology inside the joint. When we think about arthritis in terms of total hip replacement, which we're talking about today, Oftentimes that arthritis is due to wear and tear of the cartilage or cartilage thinning inside the joint. This can happen for many reasons. Typically, it happens in patients in their 50s or 60s. The average age for a total hip replacement surgery in this country is around 61 or 62. Okay. But certainly patients can present in their younger years, in their 30s or 40s, with hip arthritis as well. Right. There are different reasons for hip arthritis. When you start thinking about patients in their younger years, in the 30s and 40s, oftentimes there's either dysplasia in the hip, which is a developmental issue where the actual shape of the cup and socket of the hip doesn't develop properly. There can be infectious reasons for arthritis in the hip in the young. Another common cause for patients in their younger years to have arthritis is impingement. So there can actually be impingement between the ball and the socket of the joint. The most common type of arthritis is called osteoarthritis, and that's classically what you think of when you think of the wear and tear type arthritis in the joint.
Sure.
And that's really based on two different things. There's a large genetic predisposition to developing osteoarthritis, and then patients who have had prior trauma in the joint, this can accelerate the wear and tear in the joint.
Yeah.
In patients in their 50s and 60s, they can also have inflammatory type arthritis, which is a rheumatoid or an autoimmune type process that results in the body actually turning on itself and degenerating the cartilage in the joint. So there's a lot of different reasons that patients can come in with arthritis.
Yes.
But really the treatment for that type of arthritis can be very similar depending on what type of arthritis they have. But a lot of times the conservative or non-operative treatments are similar, and then the end of the treatment, if all those non-operative treatments fail, it would be surgery.
Yeah, got it.
Yeah.
Okay, so what are the treatment options for arthritis of the hip? And let's start with the non-surgical treatments that are out there.
Sure, and I think if you come in to see me in clinic, you'll see that we always try to do the non-operative treatments first. Right. And surgery is kind of a last resort. So if all of the non-operative treatments fail, we start thinking about surgery. But in terms of the non-operative treatments, there's multiple mainstays of treatment. So the most common is an anti-inflammatory medication. So patients can take that either orally or there's topical anti-inflammatory medications. Typically, the topical anti-inflammatories work better in arthritis of the knee or joints that are more superficial.
Yes.
The hip's a little bit of a deeper joint, so they don't work as effectively.
Okay.
But over-the-counter medications can be effective, such as Advil or Aleve.
Right.
There's also prescription-grade anti-inflammatory medications, such as meloxicam or diclofenac, that can be taken once a day and do have a good effect on limiting the pain in the hip joint. Right. Physical therapy is often a quite effective intervention as well. A lot of patients find that when they strengthen the muscles around the joint, it actually stabilizes the joint a little bit and they do get some pain relief. Yep. There are supplements. Some patients take nutritional supplements that they feel like helps with their symptoms. And then we also have injections. So similar to the topical anti-inflammatories, the injections are a little bit more difficult to do for the hip, so we don't use them as frequently as we do for the knee. But using ultrasound guidance or fluoroscopic X-ray type guidance, we can do injections into the hip. Okay. And we can do cortisone or something called viscosupplementation, where we actually provide an extra lubricant for the hip joint. And some patients get weeks to months or even up to 6 months or more of pain relief from those type of injections. And so they can be very effective. Yeah. Depending on how severe the arthritis is in the hip, we try to prolong the non-operative treatments if we can. Sure. For patients with mild or moderate disease, we try to keep those non-operative treatments going for months or even years if they can. And some patients do very well with those non-operative treatments. For patients with severe arthritis, we always, again, start with the non-operative treatments, but if they don't seem to be working in the short term, then we start having serious discussions about surgery.
Great. Great, Doc.
Yeah.
So who would then be a candidate for hip replacement surgery?
Sure. That's a great question, and it's something that I discuss with my patients all the time in clinic.
Yes.
Like I mentioned, we do like to see evidence of arthritis on the x-rays, and I like patients to have moderate, at least moderate, but ideally severe arthritis, meaning really the cartilage has almost completely worn out. Right. And on the x-rays, you can see severe arthritis because there's bone on bone, so basically the bones are starting to rub on each other. These patients have tried the non-operative treatments, and they feel like that they're not really getting the job done. Right. And then it really becomes a personal decision in terms of when is the right time for surgery. So it's important to clarify that total hip replacement is a truly elective procedure. There's never an emergency really to do a total hip replacement, with the exception of some types of trauma. So you're not going to make the surgeon's job that much more difficult by prolonging surgery.
Right.
So it's really a personal choice, and I often tell patients when they feel like their hip is starting to run their life, that it's time to start thinking about surgery. And what that means is that they can't do the activities that they want to do anymore. They feel like, you know, maybe I was going to go on vacation, but I'm not going to go on vacation because my hip's bothering me too much. I have a graduation or a wedding, and I'm worried about going to those type of events because of my hip pain. And even simple daily activities such as going up and down stairs or walking a couple blocks becomes difficult.
Right.
A lot of patients with severe arthritis start to use a cane or even a walker because their pain gets so severe. And when it gets to that point, that's where it's time to start thinking that maybe surgery is the right thing.
Yeah, great.
Yeah.
So what is total hip replacement surgery? Exactly.
Sure. So total hip replacement surgery is similar to what it sounds like, where we replace the entire joint. There are different types of hip replacement surgery, and I think that's important to delineate, is that there's something called hemiarthroplasty, where we replace part of the joint.
Right.
And that's replacing just the femoral side.
Okay.
So if you look at the hip joint, and I do have a model here,
Yep.
the hip joint is really a ball and socket joint. So there's a femoral head. This is the prosthetic one, but you know, before you do a hip replacement, this is the bone, and then there's a cup.
Yes.
And in a partial hip replacement, we're replacing just the femoral part of the hip. The acetabulum, or the cup, remains in place.
Right.
Now this type of treatment is really reserved for patients who come in with fractures.
Yes.
And the elderly, typically patients that are in their 80s or 90s when we think about hemiarthroplasty.
Yes.
The reason for that is that if you replace just the femoral side, the inside of the acetabulum is lined with cartilage, and that can wear out over time. And they've done a fair amount of studies on that, and they find that that cartilage wears out over a 5 to 10 year period. So the rate of revision to a total hip replacement in that 5 to 10 year period starts to get pretty high.
Right.
So for patients who are younger or who have elective procedures for arthritis, we tend to gravitate towards a total hip replacement. And what that is if you look at the femoral side, we make a cut in the femur, and we remove the femoral head.
Right.
Then we place a titanium stem inside the femur. So the femur is prepared to accept this titanium stem, and it's press fit, meaning that the femur is prepared so that this stem sticks to the bone.
Right.
That's how we do it without cement.
Right.
There's been a fair amount of research now on using cement versus not using cement.
Okay.
And for patients who are in their older years, you know, in their 80s or 90s, who have poor quality bones, cement actually is probably a better choice.
Okay.
We then put a metal or ceramic head on top of that titanium component. And for the acetabulum, we actually remove all the cartilage inside the acetabulum, and then we put a titanium cup in there, and that serves as the hip replacement. So basically all the articular surfaces that were lined with cartilage are now replaced with metal and plastic, and that serves as the new hip.
Got it. That was great. You know. Okay, so how long is it going to last? You know?
Well, that's a really good question.
Yeah.
So this has been also a very serious topic of debate and research over the last 10 years. So if you look back at the history of total hip replacement, it actually started in the late 1800s, and the first hip replacements were done with ivory.
Right.
And those didn't last more than just a couple years. In the 1900s, there was a very famous surgeon named Sir John Charnley who developed the modern hip replacement, and that was a cemented steel femoral component and a plastic acetabulum, and that would last anywhere from 10 to 20 years.
Right.
The major improvements that we've made in the last 5 or 10 years is the plastic, which was what typically used to wear out.
Right.
Now we use what's called a highly cross-linked plastic, and it's much more durable than it used to be.
Right.
So we don't have studies out long enough to specify exactly how long it lasts. We do have studies out to about 15 years or so, and it shows very good outcomes. They've done simulator studies where they do millions of cycles on this type of plastic to determine how long it would last. And from the best indications, it looks like it'll last over 30 years.
Right.
So when I talk to patients about hip replacement now, I say, you know, 90% or more last 20 years, but we hope it lasts 30 years or more.
Great. Great. So what's changed about hip replacement surgery in the last decade to account for the increase in procedures and the younger patients who are having it?
Yeah, so a lot of improvements have been made over the last 5 to 10 years. We talked about some of the materials that we're using, but some of the biggest improvements have actually been in the anesthesia and the pain control after the surgery.
Right.
So these days we're using spinal anesthetics, so the patients are not fully asleep during the surgery. They do receive a sedative so they don't remember the surgery, but they're breathing on their own.
Right.
We use regional anesthesia, which involves nerve blocks, which can last for 1 to 2 days,
Right.
that keep the patients comfortable. We also do something called a periarticular injection, where we inject anesthesia all around the joint, and that also can last several days. So patients their recoveries are much quicker, and I think their pain control is much better after the surgery.
Right.
Patients are staying in the hospital about 1 to 2 days,
Right.
so we're doing rapid rehabilitation as opposed to 10 years ago, patients would stay in the hospital for 5 days or more.
Right. Right.
It's much more common for patients to go home after surgery as opposed to a rehab facility.
Right.
And we've actually done some studies now looking at the risks of going home versus to a rehab facility. And patients typically, if they're healthy and they have help at home, they actually do better. There's less risk of infection or other significant complications when they go home.
Yep.
And they're familiar with their surroundings, and they typically seem to enjoy the recovery a little bit more when they're at home.
I can see that, sure.
Yeah. So those are some of the improvements we've made recently in total hip replacement.
That's great. So what are the different approaches for total hip replacement?
Sure. So classically, the most common hip replacement approaches were the posterior approach, which is over the back of the hip,
Yes.
and the lateral approach, which is over the side of the hip. The anterior hip replacement is another option, and it's actually a technique that's been around for quite some time, but it's really gained popularity over the last 5 years or so in terms of doing total hip replacement surgery. Posterior approach and lateral approach are really not the gold standard, but they have been the most commonly used approaches. And they work very, very effectively for the majority of patients, and total hip replacement is a very effective and successful procedure.
Okay.
The benefit of a posterior approach is that if you do ever need a revision surgery in the future, meaning if the hip wears out or there's a complication, that approach is extensile, meaning you can extend the incision a little bit and do the revision through that approach. Patients do very, very well because of the modern anesthesia and pain control, and they do typically stay in the hospital just about 2 days, so their recovery is quite quick. The lateral approach is also a very effective approach. Some studies have shown that the rate of dislocation, which is one of the major complications after hip replacement, although very rare, probably 1% or less, is a little bit potentially lower with the lateral approach. I don't personally do it because it requires taking down a fair amount of muscle, especially the ones that stabilize the hip when you're walking.
Yeah.
So I feel like there's the risk of limp after surgery is a little bit too high for my liking.
Good. So then tell us about the anterior hip replacement.
Yeah, certainly.
So
the anterior hip replacement is a muscle sparing approach, meaning you don't have to cut any muscles, you don't have to cut any tendons. The posterior approach and the lateral approach, which we just talked about, you do have to cut some muscles and tendons. For that reason, there have been some studies that have been coming out in the last several years showing that the recovery is probably a little bit quicker after an anterior approach. And it also may have a lower risk of dislocation compared to a posterior approach after surgery. So for patients who want to get back to strenuous activities, they want to be able to flex their hip up all the way to their chest. They don't want to have any restrictions after the surgery in terms of the type of movement that they can do. The anterior approach is probably a better choice. And it certainly has its risks, but the studies recently on the anterior approach have shown that in the first 6 weeks after surgery, there's probably a little bit of a quicker recovery in terms of getting rid of the assisted device like a cane or a walker, going up and down stairs and walking several blocks. In terms of pain control, there may be a slightly reduced risk of pain after the surgery as well. So there's some benefits of the anterior approach, and there are certainly some drawbacks, which we can talk about as well.
Yeah, and that's basically, you're not cutting as much muscle, so it's going to be a quicker recovery.
Exactly, that's the thinking.
Yeah. Okay. So, so what are the benefits to patients for this procedure?
Yeah. So we talked a little bit. We talked a little bit about those benefits. Like I was saying, for patients who want to be very, very active after the total hip replacement and don't want to have restrictions.
Mm-hmm.
With the posterior approach, we typically have about 6 weeks of restrictions in terms of their movement.
Yes.
And that's not flexing the knee up to the chest, not crossing the legs, those type of things. You don't have to worry about that after the anterior approach.
Right.
Like I said, patients have potentially a quicker recovery. They may get out of the hospital a little bit quicker.
Right.
And the risk of dislocation may be a bit less compared to the posterior approach.
Mm-hmm.
But these are things that are still under significant study,
Mm-hmm.
and so it's going to be a little bit more time before we can say definitively that
Yeah.
these are significant improvements over traditional approaches.
Okay. So is every patient better off having this type of procedure, or are there specific circumstances where there is a better approach?
Yeah, so
Yeah.
patients who are certainly having a revision procedure or
Mhm.
redo procedure, I wouldn't recommend the anterior approach.
Okay.
That's when we start thinking about doing the posterior or the lateral approach. And then when you talk about the risks, for patients who don't want to accept the risks of the anterior approach, the other approaches have been around longer and have been used a lot more frequently, so
Yeah.
I think they're a little bit, better described. One of the risks of the anterior approach, which I think we'll talk about in a little bit, is that there can be some numbness over the side of the thigh.
Yeah.
And then preparing the femur can be a little bit more challenging. So some studies have shown a little bit higher risk of fracture around the femur.
Mm-hmm.
But I think it's important to tell patients that it's important to know about the risks, but it's important not to worry about them as well, because
Right.
these risks are extremely rare.
Got it.
This is less than 1% of patients, and the
Yeah.
vast majority of patients do extremely well after total hip replacement surgery.
Great. So
Yeah.
which patients would not be a good candidate?
Yeah, that's a good question as well. So a little bit depends on body habitus. That
Mhm.
may dictate the type of approach that we can do. Another is the deformity within the hip joint. So some
Mhm.
patients with bad dysplasia, meaning their hip socket didn't form properly,
Right.
it can be a bit tougher. And certainly any patients that are having a revision or a redo of their total joint replacement, that would not be the best choice doing the anterior approach.
Got it. So what are the risks? Are they the same as the other hip replacement surgeries?
The main risks are the same. And so the highest risk is dislocation.
Right.
And like I said, it's very rare, less than 1%, but it's still a risk.
Got it.
And that's the biggest risk.
Yeah.
The second most common risk after hip replacement surgery is infection.
Right.
Again, a very rare complication, less than 1%,
Mhm.
but regardless of the approach that you do, that risk is the same. No studies have ever showed a different rate of infection depending on the approach.
Got it. Great.
So those are really the main risks, and it doesn't matter much which approach you're using.
Got it. Great. So does it require a high degree of specialized training, or can most hip replacement surgeons adapt to this technique?
So I think for a patient who's trying to find the right hip replacement surgeon, the important thing for them to know is to pick somebody who's specialized in hip replacement surgery.
Mhm.
And that typically means that that surgeon has done a fellowship in joint replacement, meaning they've spent a year or more doing just that type of procedure. So
Sure.
you want to find somebody who specializes in hip or knee replacement surgery. They do hundreds of cases per year, and that's probably the most important thing when you're looking for a hip replacement surgeon. So that's one thing that I'd stress for patients when they're looking for a surgeon.
Yeah. Okay, great. So what do you see in the future for joint replacement surgeries? And are there
Yeah.
other new procedures that are under development now, or new technologies?
Sure.
Yeah.
So I think the end goal is to not have to do surgery anymore.
Yeah.
Arthritis is an extremely common problem, and it's so frequent that everybody knows somebody who's had a total joint replacement procedure, and certainly it does come with risks. So down the road, I think we'll find better non-operative treatments to treat arthritis.
Yeah.
I don't know if there's ever going to be an intervention, during my career where we
Right.
can prevent surgery,
Yes.
but certainly there'll be treatments that can prolong, surgery if we can.
Sure.
In terms of the surgery itself, I think that some of the newer developments are the technology that we're using for this procedure. So I use computer navigation for some of my joint replacements. And what that does is it helps the surgeon be more consistent. So the surgeons are typically very good at putting the implants in the correct position.
Right.
But every now and then there are outliers, and studies show this time and time again that a small percentage of patients are outliers in terms of their component position. So
Sure.
the computer navigation helps us eliminate those outliers.
Yeah.
So I do use it sometimes when I feel like there's a risk of having one of those outliers. So I think technology in the future will help us minimize those types of errors during surgery. Another potential improvement over joint replacements is that we're going to continue to work on the materials that we use. The plastic that we're using now is very, very durable and probably lasts 30 years or more. Okay. But we're working on coming out with better materials that can last even longer.
Sure.
In the early 2000s, we were using metal on metal.
Right.
And a lot of surgeons thought that that might be the answer to the plastic wearing out problem.
Yeah.
But what we found out was that the metal actually would release metal particles, and that would cause an inflammatory type response that could damage muscle and bone and tendons, and we'd actually have to go back in and revise the hip joint.
Yeah.
So I think it's important as we develop new technologies to make sure that they're safe and that there's good evidence over a long period of time that it works before we start changing things, because the surgery as it is now is so effective that it's hard to make improvements.
Leave it alone if it's working so well.
Exactly.
You know? I have a last question for you then.
Sure, yeah.
Okay? If you have this hip replacement, anterior hip replacement,
Yep.
and you go to the metal detector at the airport,
Yep.
are they going to bring you over to the side, or what's going on there?
So yeah, patients ask that all the time. And a lot of the patients will get cards, you know, that show that they've had a joint replacement.
Yeah.
But like I was saying, this type of procedure is so common that the
TSA people.
TSA at the airport has seen it so frequently that all you have to say is, you know, I've had a hip replacement or I've had a knee replacement.
Yeah.
And they typically will send you through the scanner, but they're so used to seeing this type of thing that I've never had a patient say, you know, I got held up in the airport or I had a tough time getting through security. So it's usually not an issue for the patients.
Hey, great, Doc.
Yeah.
Doc, thank you for being
very
on the
nice
show.
talking to you.
It was a pleasure having you here. It's very informative.
You.
Dr. Berliner, by the way, will be giving a seminar about this anterior hip replacement at Greenwich Hospital on the evening of January 10th. You can also learn more by going to ONS website, onsmd.com. Thank you, and look forward to seeing you on the next show.